Good morning, ladies and gentlemen. So far, we've had a wonderful conference, and I know you're going to enjoy very much our two distinguished speakers today. We have two lovely physicians, very successful in their own right, but also two very Christian ladies. Every Sunday, we pray together with the beautiful family of Eleni and Penny at our Archdiocesan Cathedral in New York. They come every Sunday, and no matter how busy they are, they never miss the church. So they're a great example for all of us. Dr. Eleni Andreopoulou is an associate professor of clinical medicine in the Department of Medical Oncology at Weill Cornell Medical College, New York-Presbyterian Hospital. She was previously a member of the faculty in the Department of Breast Medical Oncology at the University of Texas at the MD Anderson Cancer Center. In addition to her active clinical practice, her academic interests include innovations in drug development of personal molecular therapies to effectively treat breast cancer, as well as multidisciplinary research strategies in collaboration with laboratories to interrogate cancer biology and elucidate mechanisms of drug sensitivity and resistance. With a bio like this, you can understand what kind of a talk we're going to have. Dr. Andreopoulou completed her training in major academic institutions in both Europe and here in the US. After she completed her residency in internal medicine at St. Bartholomew's Hospital in London, coincidence, she was awarded a European Society of Medical Oncology Fellowship and trained at the Royal Marsden Hospital Institute of Cancer Research in London. This experience was key to her understanding of the complexities in preclinical and clinical evaluation of anti-cancer drugs and established a strong foundation in her personal career. Subsequently, she completed her fellowship in hematology and medical oncology at NYU School of Medicine, where in addition to intensive and comprehensive clinical training, she worked personally in clinical trial design and development, investigating novel drugs in breast and gynecological cancer. Dr. Andreopoulou leads several investigator-initiated clinical trials sponsored by both the Cancer Therapy Evaluation Program at the National Cancer, we are so proud of you, Institute, as well as the pharmaceutical industry. She has published several peer-review articles, reviews, editorials, and book chapters, and has given multiple lectures at international and national breast cancer conferences. She has also been very active and played a key role with breast cancer awareness programs for early detection, screening, and prevention, with a particular focus locally of undeserved minorities. She's a member of the European Society of Medical Oncology, the Royal Society of Medicine, the American Society of Clinical Oncology, and the American Association for Cancer Research. Dr. Andreopoulou is married to Andrew, right here, our beloved Andrew Padzis. They have two adorable children, Jonathan and Alexia. Alexia is one of the favorites of His Eminence because every Sunday she finds the Archbishop when he's at the cathedral and asks him, "Your Eminence, how do you like my dress?" That is the way she approaches him. They reside in Manhattan, and she is a humble but very, very successful woman and a personal friend. Please help me in welcoming Eleni Andreopoulou.
Thank you, Paulette. Thank you for the kind introduction, and I'm going to be more simple. It's an enormous privilege for me to be here today in the presence of Your Eminence, the respected members of the clergy, and in the company of the distinguished Leadership 100 family. Before I talk to you about the state of affairs in cancer medicine, I would like to touch on what brought me to medicine, what brought me to this field. And it was my deep-rooted desire to engage on a professional structured value serving humanity. It was o anthropos. I'm the daughter of immigrants who was born in America and was raised up in Greece. And I was taught to value the pride of Hellenism, the pride of our church, and education. And in my mind, all these three are interconnected. But it was really my father who was miles ahead in terms of his philosophy on how women could contribute to the society at large and assume leadership roles. And indeed, I feel that his soul stands next to me today. What motivated me was my experiences during my medical school years back in Greece, when at that time there was a superstition about cancer disease. In fact, a lot of people used to avoid to refer to this disease as cancer, and they were referring to this as the bad disease, παλιό αρρώστια, dreading the lethal outcome and also all the disfiguring side effects of cytotoxic archaic therapy. Soon later, during my residency at the Royal Marsden Hospital in London, England, I was very fortunate that during the early stages of this training, we experienced and we witnessed the discovery and the disclosure of the Human Genome Project. That was really a turning point for the world of oncology, for me as a young clinician, and I have also the honor to say that Ilias Lalaounis celebrated this landmark discovery through his jewelry art, transmitting this message to the entire world. There is no other better way of communicating the beauty of science. Why all this is important? It's important because cancer is indeed a major public health issue. And cancers are really common diseases, and we might see the incidence increasing given the fact that the population is aging. The American Cancer Society is issuing every year projected numbers about the new cases and deaths from cancer. And I'm going to give you some numbers. I don't want you to be depressed, but it's the reality. It is projected that for the year 2015, in the United States, we're going to have 1.5 million people diagnosed with cancer. And unfortunately, we will lose 500,000. But there are good news. The overall cancer rate has decreased significantly over the last 2 decades by about 25%, and further gains are anticipated to be accelerated through enormous scientific advances and the focus on accelerated drug development. The incidence patterns in the diagnosis of cancer, they reflect on trends at the time in medical practice, in screening, and also in behavioral trends. And maybe these graphs, they don't say anything, but the one for the male that shows the peak of diagnosis in prostate cancer in the 80s was basically due to the very early detection or the overscreening and overdiagnosis using the prostate-specific antigen. We know now that this is not necessary because it's not really conferring any benefit. And for the curves on the other side, for the women, there was an increase in lung cancer in the 80s affecting women due to tobacco epidemic. And again, for breast cancer, we saw an increase partly because of the early detection through the mammogram, which is a good thing, and also because of the changes in the reproductive patterns for women. Women, they don't give birth early anymore. But again, these curves are trending down, and the curves are trending down because of the new directions in increasing awareness, increasing prevention, focusing on screening, and mainly because of advanced therapies. It's only less than 10% of the cancers that are hereditary, including breast cancer. There is a percentage, for breast cancer it's 25–30%, that are familial. This means that there is some family history, cancer runs in the family, but no specific genetic variation has been identified. The majority of cancers are sporadic. And by saying that, what I mean, during our lifetime, we accumulate a lot of changes in our DNA, a lot of damages. And unless if there is an integral mechanism of fighting these damages and repairing these damages, then the probability of developing cancer is increased. A major discovery in the 20th century was the BRCA gene, the BRCA gene, which is basically the guard in the genome. It detects the DNA damage and corrects it before this error leads to cancer development. And this is very significant because the average lifetime risk to develop breast cancer, for example, is 12% for the average population. It is up to 20% for people that they have a family history of breast cancer, but it's very high, up to 85% for breast cancer, and very increased risk for ovarian cancer for women who are carriers of this mutation. And you see here the big difference. And that was an important discovery that helped and helps a lot of women make informed decisions of how to modify this increased risk. We're all aware about the famous actress Angelina Jolie, who was a carrier of the mutation. Indeed, her mother died from ovarian cancer. By knowing that he was a carrier of this genetic mutation, made an informed decision to proceed with risk reduction surgery. I have also to say that for this particular population of patients, we had a very recent approval of a drug called olaparib, targeting this specific patient population, and it is used for advanced disease because, again, our mindset has changed. Early stage cancer, and early stage breast cancer is largely curable. I can tell you that for patients with favorable biology who are diagnosed with breast cancer, the outcome is really good. We treat them on a curative intent, and we anticipate and we're aiming to the 95% of cure rate. And the good news also is that even for patients who have aggressive biology, we do have new targeted therapy. 3 drugs actually were approved over the last decade for what we call HER2-positive disease, which was very aggressive, and this has improved the outcome by 50%. Risk modification, when patients are aware of their hereditary predisposition or of their family history, because there are several models to estimate and evaluate this risk, is including, as we saw before, the breast reduction surgery. There are medications that can reduce risk, and of course it's the awareness for following up with specific screening tests. But there are other factors for the average population, for people that they don't have any specific predisposition, that they can really be modified. And I will focus on the increased weight, on the obesity. Yes, certainly, sugars are very bad. The sugar causes inflammation. I know that there are endocrinologists in the audience, and we do have very solid evidence that there is a link to cancer. The lack of exercise, the lack of breastfeeding, the increased consumption of alcohol, hormone replacement therapy, birth control pills, women that nowadays they don't have children, all of these are factors that are contributing. We can't change the fact that we're women, we can't change the fact that we're getting older, but we can definitely modify our risk during our daily life, engaging on healthy habits. This is very, very, very important. Now, there is a lot of evidence linking environmental causes to cancer. And I can tell you, from the preservatives in our lipsticks, ladies, to the flame retardants in our sofas, to the pesticides in our fruit and vegetable, to the plasticides in the bottled water, all of these are linked to cancer. And I'm showing this slide here just to make a case that just use a simple, decent filter at home for clearing the water, because there are a lot of associations reported between the BPA, the bisphenol compound that is used in plastics. It's mimicking estrogen, the estrogen effect, the hormone effect, and it has been linked to increased incidence of cancer. And I have to tell you that it's not only this, there are 85,000 synthetic compounds out there that they're getting approval through the FDA, and they're used, and we're totally unaware of all the detrimental effects. Indeed, in 2011, the American Medical Association recognized the BPA as a toxin and identified consumer products containing BPA, and there was this program of increasing awareness, especially for the baby bottles. In 2013, the American Medical Association called for Congress to require manufacturers provide safety data on chemicals. So what shall we do? Of course, lifestyle modifications are important, but also for prevention, people have to follow the guidelines for regular screening. Screening mammogram, pap tests for women, and colonoscopy for both women and men. The American Cancer Society guidelines for screening an adult with an average risk recommend screening for breast cancer, cervical cancer, and colorectal cancer. There is clear evidence that screening reduces morbidity and mortality. For prostate cancer, this requires an informed and shared decision to be made on the basis of the uncertainty of the benefits and harms. First, because the PSA is a very sensitive marker, but not really specific, led to overdiagnosis and misdiagnosis, and the data show that this is not changing the outcome, but it basically leads in compromises in quality of life for many male. The same for lung cancer. Informed decision-making is needed because by obtaining on an annual basis a low dose CAT scans, it's a way to detect lung cancer possibly in a high-risk population, but this requires that there is no smoking. You can't continue smoking and expect that you will detect your lung cancer by obtaining a scan on a yearly basis. The current guidelines for breast cancer, they recommend annual mammogram to start at the age of 40, not earlier, unless if there is a very high risk on the basis of genetic variations. And again, the focus there is to raise awareness. Beyond all of these, I would like to talk to you about what is for me the most exciting advancement in cancer medicine. What I advocate in my daily practice is personalized medicine. I'm a passionate advocate for precision medicine, and what I practice is the multidisciplinary drug development process. Our community, the medical community, was very excited last month when the President announced at the State of the Union address the Precision Medicine Initiative. This is not news to us, but it consolidated an effort undertaken by the scientific community, in the academia, and in the industry, and supported widely by patients to come up with therapies that they precisely target specific diseases. And of course, there is a clear opportunity for precision medicine in oncology, but it's not only for oncology. This will expand to treat all other diseases, including diabetes, including neurological disorders, including immune diseases, genetic syndromes. And actually, it underscores the priorities of this great country to address major issues to improve the health of people, to make the difference not only in the United States, but internationally. So many of you may be wondering, what exactly is this precision medicine? And how can it transform medicine as it practiced today? Today, in oncology, up to very recently actually, we use therapies for the average patient. It used to be actually one size fits them all. But now it is the technology that helped us decode the alphabet of cancer disease. And this decoding started with the Human Genome Project, enabling us to learn a language. And we really needed to learn the language of cancer in order to be able to interpret the biological implications of this disease and tackle the vulnerabilities of this disease and be able to develop optimal therapy, optimal curative therapy. So the technology is available there, and it's improving day by day. And we're able to get all the facts and all the pictures looking at our genetic makeup. The targets are identified, and as I said, for sporadic cancers, we accumulate a lot of damages. We're able to detect these aberrations, these deletions, these changes in the genome. We don't know yet how many of them are actionable, but certainly there is a puzzle there that we're working on fixing and getting the entire picture. And there are thousands of researchers in both academia and the industry that are working toward making these identified vulnerabilities druggable. We're trying to develop therapies that they target these specific defects. There is a considerable number of these therapies already approved, and we use them, and they have changed the outcome of the disease. I can give you an example. The survival for the acute lymphocytic leukemia and chronic myelogenous leukemia, the 5-year survival has been doubled because of Gleevec, a targeted therapy. The objectives of precision medicine, of course, it's more and better treatment, precise treatment. It's the creation of a voluntary national research cohort. Over 1 million Americans will participate in that. We need this. We need the biospecimens to work and make the discovery. It requires commitment to protect privacy. All the data will be safely stored, and they're very important to be interpreted in the context of what will be discovered in the laboratory. And of course, the regulatory modernization of the FDA to basically accelerate the process of approving optimal promising tools to accomplish that. And it's a real collaborative work between numerous clinicians from every discipline: medicine and surgery, radiology and radiation oncology, and scientists, biologists, chemists, biostatisticians, that they all work together. And I'm really honored and humbled to work together with my colleagues at Weill Cornell toward this direction. And as a clinician scientist, every day I'm wondering about the complexities of our existence. I think the answer lies in a quote that I will read for you. This has been really touching for me. it is very important. And it is from Dr. Francis Collins. He is the current director of the National Institutes of Health. He is the one who basically led the Human Genome Project. And I'm going to read it for you. I have found there is a wonderful harmony in the complementary truths of science and faith. The God of the Bible is also the God of the genome. God can be found in the cathedral or in the laboratory. By investigating God's majestic and awesome creation, science can actually be a means of worship. It is actually what makes my practice very interesting and gives me a lot of strength every day. And at this point, I have to thank also my husband for being next to me and supports my dedication and my passion to make this difference. I thank you all very much.